Okay, so for this next part, I'm going to talk about Parkinson's. And since we're talking about Parkinson's, I think it ties very well with also why Huntington is the way it is, and a lot of the stuff with schizophrenia. So I'm going to kind of talk about all those three in one chunk. So to start off, I'm going to go over exactly what goes wrong in the disease process and what the main role of dopamine is in the CNS. So dopamine in CNS, there's two main things that are associated with dopamine, and then there are some other ones that we'll go into later. But the two main things is that first, there's the movement. And mainly it's in initiating the movement, and there's a bit of a distinction, but for now, just think of movement overall. And this is basically what they called in pharmacology like nigrostriatal. So this is basically the nigrostriatal. So that would be involved in movement. And there's another part that is involved in the CNS, and that's having to do with emotions. It has to do with reward. So by reward, we mean something that you do that makes you happy. So doing drugs for some people is also that whole system. Okay, so that's the ventral tegmental area. Okay, and with regards to movement, we have two diseases that we can typically think of that are sort of the opposite. So one of them is Parkinson's. And when we think of Parkinson's, what do you normally think of? Do they move too much, or they have trouble moving? So like they're kind of shaky, you know, they have trouble like getting the movement started, right? So if that's the case, it's more like too little movement.
But they're really shuffling?
Yeah, so they're shuffling, they're taking very small steps.
And then their hands are kind of shaking a little bit. So like you're on the right track. Like the shake is kind of odd, but like everything else is slow. So think of Parkinson's as slow.
Yeah, so slow and trouble initiating the movement. Okay, so next example I'm gonna give you is the Huntington's. So Huntington's, they call it Huntington's chorea. So basically you have like all these random movements. And you can watch videos of this. These people are not really aware that they're doing all these things. It's not really something that they're trying to do. But when they're not paying attention, they'll just be like moving all over the place. So we can basically say like, you know, for Huntington's, that's essentially too much movement. So this is too much. Okay, and now we'll go into a little bit about why these movements are the way they are. In very general terms, there's a lot of neurons involved, and I'm sure there's like a little diagram in your form notes that you saw, but it could be sort of simplified into two different pathways. Okay, so these two different pathways are like kind of a tug of war. One is trying to decrease the movement, and the other one is trying to increase the movement. So they call one of them direct pathway and the other one indirect. Don't get too hung up on these terms. The indirect, they basically mean there's like way more neurons involved, and one is inhibiting the other that's inhibiting another. So that's why it's considered indirect. So for now, you don't need to know exactly which neurons. Just know that there's a direct. In the direct pathway, the end result is going to be increased movement. And then the indirect, that's the one with a lot more neurons involved. And the end result of that pathway is decreased movement. So this is something that's happening in basal ganglia. And the disease process for Parkinson comes in here. So Parkinson's, you guys have talked about how the treatment for Parkinson is related to dopamine, right? So basically, these Parkinson's people cannot make enough dopamine. This is where it comes in. So dopamine is made in substantia nigra. And what it does is that it normally increases this pathway, the direct pathway. So if you increase the direct pathway, the end result would be you have more movement. And what it does to the indirect pathway, it inhibits it. So when you inhibit the indirect pathway, you're kind of inhibiting the decrease of movement. So the end result is dopamine will give you more movement. Okay, so if we have something wrong with this part, well, it's orange. Okay, so if we have something wrong with this dopamine here, there's a lack of dopamine. Do you think we'll end up getting too much movement or too little? Too little, right? So this is basically what happens in Parkinson's. The neurons that are making the dopamine that's feeding into these pathways for movement, they're just kind of atrophied. They're not really there. They're not making enough dopamine. So that was the problem with Huntington's disease. Parkinson's disease. And can you imagine for Huntington's, which one of these pathways are affected? Is it direct or indirect? If you're gonna say like, okay, one of them is not working, which one would it be? The direct or indirect? Yeah, it would be indirect, right? So this is the problem with Huntington's. It's basically this pathway is somehow not working. Okay, so now we'll go into a little bit about Parkinson's disease and how we treat it. Then go down a little bit more. Oh, actually, before we go there, there's also another little thing that's affecting this. So this indirect pathway here, it's also affected by acetylcholine. And what acetylcholine does is actually increases this pathway. So the effect of acetylcholine you would expect would be more movement or less movement. So it's feeding into this indirect pathway, decreasing movement. So effect of acetylcholine would be to decrease movement, less movement. Okay. So this, just have that somewhere in your mind. We're going to talk about it later in some of the treatments for Parkinson's. Okay, so if the problem in Parkinson's is basically too little dopamine, what would be like the most logical approach? You want to somehow maybe give them more dopamine, right? And you want to give it in the right location, which is in your brain. So these two facts are very important. So target for Parkinson's disease treatment. Okay, you want to increase dopamine, and you want to do that in the CNS. So that's the target of the treatment. And let's think about the body is like basically two different compartments. So the idea is, here is a CNS. This is rest of the body. And then what's separating these two is the blood-brain barrier. And we're saying like we want to increase dopamine and we want to do that in the CNS. So ideally, we want to have dopamine here. We want to increase dopamine here. So the problem with just giving them straight dopamine is you're obviously going to take dopamine somewhere in you're going to take it orally or something, but it's going to go into periphery. It's not going to go straight into your CNS. And the problem with dopamine is that it can't really cross this blood-brain barrier. So this part doesn't work. So obviously, we have to come up with a way that will get something into CNS. So since dopamine doesn't work, the precursor, levodopa is able to cross. And then once it crosses, it will get made into dopamine. So that's what we're after, having the dopamine in the CNS. And levodopa is so this is like a prodrug. And this is the goal. We want to give them levodopa and then have that cross into the CNS and then get converted into dopamine. And that's the goal. That's the goal here, ideal. And to make that happen, we have to think about some of the things that could go wrong in this whole process. So dopamine, levodopa, if you want it to cross into CNS, obviously you don't want it to be made into dopamine in the periphery, right? So there is an enzyme, it's like a decarboxylase. It's like a decarboxylase that converts levodopa to dopamine. So if you want to enter the CNS in the levodopa form, you don't want this to happen. So you want to inhibit this step. And this is where the carbidopa comes in. Okay, so carbidopa will inhibit the decarboxylase from converting levodopa into dopamine in the periphery. So we don't want that to happen since dopamine can't cross in the first place. Okay, and then there are some other ways that L-dopa can be converted to other things. It can be converted into other metabolites. And there's also the COMT. COMT can convert the levodopa into other metabolites, and then if it's converted into metabolites, it's already not really working. So we want to target that as well. Okay, so you guys learned about the tocopone and entacapone. Those two drugs will inhibit this COMT. So the idea is we want to get the levodopa into CNS and then kind of eliminate all the other ways that it could be broken down before it gets into the CNS. And another pathway that it could be made into metabolite would be MAO. So, MAO. Okay, so once it's in the CNS, so we have all these drugs that will help the levodopa get into the CNS. So this, you can think of it as levodopa and carbidopa, right? These two are usually used together. Carbidopa. These two are used together to get the levodopa into the CNS. And now when it's in the CNS, you also want this dopamine to last as long as possible. So you also want to prevent the breakdown here. So this one can be broken down into metabolites and then they're no longer useful. So the enzyme that breaks down here would be MAO, and it could be COMT. And we also want to inhibit things here. So MAO inhibitors, especially the one for brain, would be like selegiline. Okay, so the treatment for Parkinson mostly would be give them the levodopa-carbidopa. So that will ensure that levodopa gets into CNS. And then once it's in the CNS, you want to prevent the breakdown by giving a MAO inhibitor. And you would also want to prevent it from being broken down when it's in the periphery. So carbidopa will do that, and then the tocopone, entacapone will do that. And then tocopone also will inhibit it here. So that will help the dopamine remain in the dopamine form in the CNS. So that's the main treatment for Parkinson's.
What were those again?
Which one?
Levodopa, carbidopa. Another combination said levodopa and selagine.
Okay, so first what you want to try for Parkinson's is levodopa-carbidopa. If that doesn't work, you can try COMT inhibitors and MAO-B inhibitors. So this is first line. First you want to try this. First, you can also try just dopamine agonists. And that would just be affecting directly here. So you want to do dopamine agonist, or you want to give levodopa and make sure it gets to the CNS. So that's the first thing you try. And if that doesn't work, you can try things that will inhibit the breakdown of dopamine. So then you can add something like tocopone or entacapone, right? And now if that's still not working, you can also try this one that we mentioned up here. I'm just going to scroll up to this part. Remember we talked about acetylcholine, how that would decrease movement. So to increase movement, what would you want to do with acetylcholine? Block it somehow, right? So muscarinic agonist can also be used. So you can use antagonist. So that in theory should also, you're inhibiting the stimulation for the decrease of movement. So in the end, that should increase movement. Okay, so but the first line of treatment is definitely the levodopa-carbidopa. Then you try harder to get the levodopa into the CNS, right? Or you can also try something that will affect acetylcholine. So those are like the benzotropine, and then trihexafenadil, yeah. So I'll have the list for you here. I'll post the list later. But does that make sense that these are the way we try to target it? Levodopa-carbidopa first, or you can do dopamine agonist first. Then, if those are not working, you do MAO inhibitor, COMT inhibitor, or muscarinic antagonist. So think about these as like the main treatment and then other things to do if the main one doesn't work. Okay, so let me pause this for now.